Morning. Today we are going to do a cooled radiofrequency of lumbar median branch for the low back pain due to lumbar facet syndrome. Normally what we do is the conventional or standard radiofrequency using these radiofrequency cannulas, where you can see this is curved and this is 18 gauge cannula, and we place it parallel to the nerve, that is the medial branch. But in the cooled radiofrequency, it is important to understand the difference that we are using this cannula, which is a cooled radiofrequency cannula. It has 17 gauge in the diameter and with the 4 of active tip. So there is a difference between the placement of these RF cannula while doing the standard radio frequency or the cooled radio. For the standard and radio frequency, we need to put the cannula parallel to the nerve to get it burned mostly. Why? Because the lesion of the standard radio frequency happens on the side of the active tip. But in the cooled radio frequency, the lesion is being made at the tip of the cannula. I had the tip of the cannula. So that makes the difference of the placement of these radio frequency while doing the cooled versus the standard. Benefit are with the cooled radio frequency, it is more operator friendly. But then there is a side effect if you are wrongly placing these cooled radio frequency probes in the same manner as you place the standard radio frequency probe. There are good chances that patient may be harmed by the unintentional nerve damage. So we will show you how to we do it. So patient is in the prone position under local anesthesia only. We are using a C-arm guidance, and we practically do it in the same manner as we do the median branch block or the diagnostic MIPSI for the lumbar facet syndrome. So here on the C-arm, we have already done the diagnostic median branch block for this patient of the bilateral L3, L4 median branch as well as the L5 dorsal root. So patient had a very good relief of more than 70% with the diagnostic intervention. That's why we have planned for the median branch cooled radiofrequency. First we do the squaring of the thing. माँ आराम से लेटिए. Done the squaring and we have done the axillateral oblique. माँ चीटी काटेगी. खून करने की दवा दे रहा हूँ. Put the local anesthesia for the median branch area of the L5 dorsal root. Now for the L4, again on the bone side only, you can see the tip of my needle which is at the junction of the transverse process and the superior articular process. So now we have given the local anesthesia for the three nerves of the left side. Now we are going to place this 17 gauge cannula at the junction. Our aim is the junction of transverse process with the superior articular process, not beyond that. We are going in the gun barrel view. And now we are going to put another cannula for the L4 median branch, again in the gun barrel view. And hitting the bone only. The same way we do the median branch block. The same way we are going to do the cooled radio frequency of the branch. So this is marked difference between the, and this difference is very important to keep the patient safe. So we have I am on the bone. That I am on the bone. The same manner we are going to put the last cannula of the left side, L3. Now we are going to check it in the AP picture. Some correction just to reach the. बस माँ क्लियर नहीं. You can see that the tip of our inner cannula is reaching up to the foramen. And if we remove the stilate, now you will see in the upper where we are. So now perhaps you can appreciate where we are. And now this is the of the radio frequency, cooled radio frequency, which will go inside the patient. And now again we check it where we are. So you can see the tip of the radio frequency probe, which is reaching up to the middle of the facet, not beyond that. It is not reaching up to the foramen because lesion is going to be going ahead of it. Now we are going to put another and again check the depth. So we see that we are quite far away from the foramen, but still now we are going to check the sensory and motor stimulation, which is where asking the patient in her language when she feels the tingling only in her back, she should inform us, and if she is feeling any tingling going down the leg, she should also inform us. So we are going to do the sensory stimulation at 50 Hertz as well as the motor stimulation at 2 Hertz. And it is very important step. You must not forget it or miss it. So one by one we are going to stimulate. Show the machine. This is the most advanced Cooled radio frequency pain management generator. Now do the motor at 2 Hertz. Now it is very important to see whether there is any contraction of muscle down the leg. You can see slight multifidus contraction on the local side, but no stimulation up to 1 volt into the leg. So that means that we are quite far away from the motor nerve, which is very important. Now we are going to repeat the same exercise at the B and C cannula of the sensory and motor stimulation. So now we are going to use this channel given with the cannula to inject some local anesthesia to make the procedure comfortable. So 1.5 minutes, 2 minutes before we start the lesioning. And while lesioning, again we will keep a close watch on any neurological sign and symptom, because please remember the safety is paramount. Now we are going to make a lesion of 2.5 minutes at this is most advanced machine, which is a 4-channel machine. So we are using 2 burettes, but for the 3 cannulas. So we have used a Y connection here, Y connection. So that makes again a life of pain physician easy, because we can simultaneously make 3 lesions using this machine. So this is one of the most advanced. Started the lesioning. You can see that water has started running from the burette to the radio frequency cannula, and temperature has started rising there. Asking again and again to the patient regarding any symptoms, neurological symptoms in her leg, and this is the reason we do not give any kind of sedation to the patient while doing these procedures. These are MIPSIs, minimally invasive pain and spine interventions, which are percutaneous, minimally invasive, but they are potentially risky. So we cannot have a chance to make our patient knocked out using a lot of fentanyl and midazolam, etc. And they have to be done. Patient has to be conscious, oriented, time, place person, and should be able to respond to our queries. The temperature has reached up to 60 degrees. Cooled radio frequency, and we have tried at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, India, in the pain medicine unit of Department of Anesthesiology, to differentiate between the standard radio frequency and the cooled radio frequency, and these differences are important. We are going to repeat the same thing on the other side after doing it. So happy watching, and thanks.